Welcome to the lecture entitled Medical Imaging of the Breast. This presentation was developed by Dr. Carlos Suarez-Quian of Georgetown University, Dr. Joel Walensky of Huntington University, and Dr. Edward Weber, a retired radiologist. It is being narrated by Dr. Suarez-Quian. Let's begin. The objective of this presentation is to provide you with basic knowledge on breast imaging. Let's start with the obvious question. What is the clinical need for breast imaging? Here are the facts. Decades after its incidence in women were first reported in the 1940s, breast cancer will develop in 1 in 8 women, an identical statistic that remains to this day. Breast cancer is the most common visceral cancer in U.S. women. Breast cancer is the second most common cancer mortality in U.S. women, and breast cancer is the most common cancer mortality in U.S. women aged 40 to 55. Hence, the answer is clear. When there is a clinical suspicion of breast cancer, definitive diagnosis of benign and malignant disease is almost always dependent upon radiological imaging. But more importantly, screening of asymptomatic women for this disease has been shown to reduce mortality from breast cancer. As you likely know, the breast is a variable size prominence located on the front of the chest wall. In women, it contains a glandular tissue, which are active during lactation. Most of the prominence of the breast is due to fat or connective tissue rather than glandular material. Because lactation is associated with childbirth, the breast tissue is very sensitive to the monthly hormonal changes that occur in women. Unfortunately, this hormonal cycling has been implicated in the glandular tissues of the breast becoming susceptible to malignancy or cancer. The primary imaging modality for examining the breast is mammography, a radiological procedure that is optimized for the evaluation of breast tissue. A mammography unit is designed to confine a remarkably minimal radiation exposure to a single breast, which is somewhat flattened by compression paddles. You can stop the movie if you wish to look more closely at the different components of the machine. Screening mammography is done on asymptomatic women with a normal physical exam in order to detect cancer early enough to improve patient outcome after the diagnosis, ideally a cure. In contrast, diagnostic mammography is done to characterize the nature of clinically suspicious signs and/or symptoms of breast cancer. In a typical mammogram, the breast and a limited portion of the axilla and pectoral muscles are within the field of view. In addition, contrast resolution provided on mammography images is limited, with few radiographic densities appreciable for diagnosis. In this image, there are 3 distinct densities that can be discerned. 1. The dark shade of gray, representing fat. Lipids have lots of hydrogen that doesn't stop or scatter many X-rays. 2. The intermediate shade of gray, representing soft tissue that includes fibrous and glandular tissue and are indistinguishable from one another. Hence, the term fibroglandular tissue, water, for example, fluid in cysts and tumors. Finally, 3. White or near white of calcifications. Now examine this image and observe the area highlighted in red. Detection of malignancy by mammography depends upon high spatial resolution and appreciation of abnormal patterns of soft tissue and calcific densities. A radiological report of such an observation would likely state the following: nodular soft tissue density, which requires further evaluation. Imaging findings of possible malignancy may be very subtle. Many imaging findings are not caused by malignancy. Computer algorithms now aid diagnostic radiologists in detecting such patterns. There are two standard views in screening mammographic exams: craniocaudal and medial-lateral oblique. In the craniocaudal view, the X-rays traverse the breast from top to bottom. In the medial-lateral oblique view, the X-rays traverse the breast at a 45-degree angle. The next two slides show examples of each view for both breasts. Here, we demonstrate the craniocaudal appearance of both breasts. The convention is to display the lateral margin of the breast facing upwards. In this patient, the predominant radiographic density is that of fat. This will be discussed momentarily. And here are the medial-lateral oblique views of both breasts. Note the oblique additional density of axillary folds. By convention, the axilla are displayed facing upwards. A variation of a routine mammography is digital tomosynthesis, commonly called 3D mammography, which can reveal findings not visible on routine projection mammography. The procedure is the same from the patient's point of view, although it will take a few seconds longer. As shown in the slide, at the point of the arrow, architectural distortion can be more readily appreciated using this enhanced imaging modality when compared to 2D mammography. Another new technique being studied is contrast-enhanced mammography done after the IV injection of iodine-based contrast agent. Low-dose CT scanning optimized for breast imaging is also being studied. Importantly, this leads me now to discuss why there remains a need to continue improving our ability in how to image the breast. And the reason is quite apparent. Breasts present differently in imaging studies based on their density. Breast density refers to the ratio of fat tissue radiographic density to soft tissue or fluid radiographic density. Breast density impacts not only on a patient's risk because breast cancer arises in glandular tissue, not fat, but also affects the sensitivity of breast cancer detection by mammography because radiographically dense tissue may obscure a potentially significant mass. Let's examine how different breasts will appear in mammography. Here's an image of a breast considered to be a fatty breast. Less than 25% of the area of the breast on the image is non-fatty or soft tissue density. The radiographic density seen on mammography does not correlate well with the texture of the breast on physical exam. In this second example, we see scattered fibroglandular densities. In these breasts, 25 to 50% of the area is soft tissue density. The assignment of breast density by radiologists is subjective and not highly reproducible. Now, we observe an example of a heterogeneously dense breast. In these breasts, 50 to 75% of the area is soft tissue density. Computer algorithms for assessment of breast density are undergoing validation. Finally, Let's look at an example of an extremely dense breast. In these cases, less than 25% of area of the breast is fat density. One can easily see how a small mass with the same radiographic density as this extensive fibroglandular tissue could be obscured. I have now combined all four types of breasts in one slide so you can compare, and yes, realize that the classification is open to investigator interpretation and bias. AI will likely minimize confusion in the future. By law, in the U.S., breast density is reported to patients who have had mammography. The last two categories are reported together as dense breasts. The intent of mandated reporting of mammography density is to alert those women with dense breasts of decreased sensitivity in detecting early breast cancer by mammography and to motivate these women to seek screening by other imaging modalities such as MRI or ultrasound. This rationale is based on 2 points of fact. Cancer arises from glandular tissue. Those with dense breasts are assumed to have more glandular tissue than women with fatty breasts and are at higher risk. And 2, because tumors and fibroglandular tissue have the same radiographic density, detection of tumors is more difficult in radiographically dense breasts, have a higher false positive rate than fatty breasts. Moreover, radiology reports on all breast imaging studies, whether mammography, ultrasonography, MRI, or scintigraphy, must include the radiologist's assignment of a breast imaging and reporting data system score, that is, BI-RADS rating. BI-RADS 0 is a commitment to the importance of having the patient return for further imaging, such as magnification mammography views or ultrasonography, before an imaging diagnosis can be made. Breast imaging facilities will follow patients to the ends of the earth to assure that they get the needed additional imaging. BI-RADS 1 and 2 are assigned when there is no imaging finding suspicious for malignancy. BI-RADS 3 is most commonly used when ultrasonography reveals that a breast mass is probably a benign fibroadenoma, and 6-month follow-up imaging is more appropriate than an immediate biopsy. BI-RADS 4 and 5 require scheduling the patient for image-guided needle biopsy. Finally, in some cases, imaging, usually MRI, is done after a diagnosis of malignancy has been proven by biopsy. In patients with radiographically dense breasts, this may be done to rule out mammographically occult multifocal or multicentric breast cancer. Because a primary lesion has already been proven to be malignant, BI-RADS 6 is assigned. And the widespread implementation of screening mammography has led to early detection of small, non-palpable breast cancers. This has been shown to decrease cancer stage at the time of surgery and has contributed greatly to decreasing the death rate from breast cancer. In the case shown, the tiny mass indicated by the 2 arrows was histologically invasive but had not yet metastasized to axillary lymph nodes. The patient was diagnosed at a very early stage, associated with an excellent long-term prognosis. Not all lesions are as clear as shown in the previous slide. This slide shows a screening mammogram that revealed a very small area of the breast containing many microcalcifications suspicious for breast cancer. Most breast calcifications are benign. At times, however, Very high spatial resolution is required for radiologists to assess whether breast calcifications have characteristically benign morphology or if they're suspicious for malignancy. Direct radiographic magnification, used in addition to electronic magnification, is required to make the initial diagnosis. Let's now move to the worst case scenario. What if a woman feels a lump in their breast? At this time, we switch to using the language of diagnostic mammography instead of screening mammography. Diagnostic mammography is done for palpable masses and when screening mammography shows a suspicious mass. The additional views and modalities used to evaluate palpable masses may reveal that a density that was seen on screening mammography is not significant. That is, it is not cancer. Here's a classic example of a patient who had not been attending yearly screening mammography and presented with a large palpable mass. Based upon its mammographic and sonographic appearance, it was assigned a BI-RADS score of 4 and the patient was scheduled for ultrasound-guided biopsy. Given that screening mammography is perceived by some to be associated with certain risk because of the use of radiation, the question becomes, why not use ultrasound? Breast ultrasound, indeed, may be used to differentiate benign from malignant breast masses. As shown here, benign breast cysts have a very conspicuous round and sonographic feature that renders them confidently diagnosed with ultrasound. In contrast, note the irregular grayish malignant mass on the right, commonly seen with malignancies. But can ultrasound without a mammogram detect breast cancer? The answer is no. Having found a suspicious mass, what next? Using local anesthesia, ultrasound-guided minimally invasive core needle biopsy is the typical procedure. In this case, a BI-RADS 3 mass was confirmed to be a benign fibroadenoma. In the image, the needles indicated by the white arrowheads and the mass by the red arrows. There has been some controversy over the standard screening recommendations of the American Cancer Society and of the Society of Breast Imaging for average risk women. However, the authors of this lecture are of the opinion that those urging less frequent screening starting at later ages exaggerated the significance of false positives and ignored many studies showing the clinical value of adhering to the recommendations of the ACS and SBI, and often continue to use a widely discredited early clinical trial. Current recommendations are as follows. Yearly screening beginning at age 40 is recommended for women at average risk. High-risk women, known genetic predisposition, predicted lifetime risk greater than 20%, are recommended to begin screening at a younger age. And breast MRI, with and without gadolinium contrast enhancement, has been added to mammography to screen high-risk women. The enhanced information that can be gained from this modality of imaging the breast is clear from this slide. At present, yearly MRI may be used instead of mammography in high-risk screening programs. In addition to lesion morphology, the kinetics of contrast enhancement in MRI can aid in the diagnosis of breast cancer. Here, for example, we show a spiculated malignant mass in the central breast that demonstrated rapid uptake of the gadolinium-based contrast agent. In addition to the medical imaging modalities of mammography, Ultrasonography and MRI work is also being done in the nuclear medicine procedure of scintigraphy mammography, but this is not being widely used. However, alternative medical practitioners have been promoting the use of thermography as a means for women to avoid the ionizing radiation used in mammography. Such promotion grossly exaggerates the risk from the incredibly small radiation exposure and absorption in mammography and is dishonest in representing that thermography has ever shown efficacy for breast cancer diagnosis. This now concludes our brief presentation on breast imaging.